Good morning, friends. Today we'll be starting with NTEP, National TB Elimination Program. This was requested by many of you. I'm sorry to upload it very late. So we'll start about evolution of TB control in India. As you can see, in 1950s and 60s, we had important TB research at TRC and NDI. Then in 1962, first TB national program was launched. Okay, but the problem was that only 30% of the patients were diagnosed, and only out of these 30 patients, 30 were treated successfully. So RNTCP was launched in 1993, and in 1998 it became scaled up. Okay, then in 2006 it covered the entire country. So Stop TB Strategy 2006. What was the vision? A world free of TB. The goal was to reduce the global burden of TB by 2015 in MDGs. What is MDG? We have also discussed before. Millennium Developmental Goals. And Stop TB Partnership Targets. Then, what are Stop TB Partnership Targets? These were by 2005, at least 70% of people with sputum smear positive TB will be diagnosed, and out of these 70 people, at least 85 will be cured. In 2015, the burden of the TB will be reduced by 50% relative to 1990's level, and prevalence will decrease from 150 per lakh population and death 15 per lakh population. Okay, and also we want that people dying from TB and co-infected with HIV should also decrease. Now our 2035 goal is to reduce the global incidence of TB less than or equal to 1 case per million population per year. Then we have revised National TB Control Program that was changed to NTEP, National TB Elimination Program, in January 2020. Only the name has changed. Some of the objectives are: first, that 90% of the notification rate for all the cases. At least all the cases should be 90% of the cases should be notified. 90% success rate for all new, and 85% for retreatment cases. To significantly improve the successful outcome of treatment of drug-resistant TB. To achieve decrease morbidity and mortality of HIV-associated TB, to improve outcomes of TB care in private sector. What is a tuberculosis unit? It is a nodal point for TB control activities in sub-district. In urban area, one tuberculosis unit is per 2 lakh population. Then what do we have in them? We have a medical officer, that is a tuberculosis unit controller. Then we have senior treatment supervisor, senior TB laboratory supervisor, and one TBHV health worker per 1 lakh urban population. Then tuberculosis unit has been will have one designated microscopy center every 1 lakh population, and 50,000 in tribal, desert, remote and hilly area like Uttarakhand. Microscopy centers are also available in medical college like ours, corporate hospitals, ESI, railways, NGOs and private hospitals. Then, what is a presumptive TB case? If you have cough for more than 2 weeks, fever for more than 2 weeks, significant weight loss, hemoptysis, any abnormality in chest radiography, these are known as presumptive TB cases. Okay, and also the patient who are in contact with TB patients or people living with HIV, diabetics, malnourished, cancer patients who are on immunosuppressants or steroids should also be screened for signs and symptoms of TB because they are more prone for TB. A presumptive extrapulmonary tuberculosis, organ-specific symptoms and signs like swelling of lymph node, pain and swelling in joints, neck stiffness and disorientation. Constitutional symptoms are like significant weight loss, persistent fever for more than 2 weeks and night sweats. What is presumptive pediatric case? If you have persistent fever, you have cough, you have weight loss or no weight gain, and history of contact. Okay, what is weight loss defined in a pediatric age group? If the weight loss is more than 5%, okay, in the last 3 months, and it is significant weight loss. Then drug resistant TB. What is a presumptive case? Patient who was found positive on any of the following sputum smear examination during treatment with your TB, and previously treated cases of TB, if they are again found again found to be sputum smear positive, then they are presumptive cases for drug resistant TB. Patients that are HIV co-infected, who have failed treatment with normal TB regime, pediatric TB non-responders, and patients who are in contact of drug resistant TB, mainly rifampicin. Then case definition. Biologically confirmed TB case is a case. Okay, it is not presumptive. Biological specimen positive for AFB, acid fast bacilli, or positive for Mycobacterium tuberculosis on culture medium, or positive through quality assured rapid diagnostic molecular test. We will read all of these types in subsequent slides. Then clinically diagnosed TB cases. Presumptive TB cases, which is not microbiologically confirmed but diagnosed with active TB by a clinician on the basis of X-ray abnormalities, histopathology, clinical signs, with a decision to treat patient with full courses of antitubercular drugs. Okay, then new cases. Patient who have never had TB or has taken anti-TB drugs for less than 1 month is considered a new case. Okay, then previously treated patient who has received 1 month or more than 1 month TB is an old case. Now we have a recurrent case and treatment after failure. What is a recurrent case? A TB patient previously declared as successfully treated and is subsequently found to be microbiologically confirmed TB case is recurrent. It was also called as relapse. Treatment after failure. Patient those who have been previously treated for TB and whose treatment failed at the end of their most recent course of treatment. They are also called as only failure. Treatment after loss to follow-up. A TB patient who has been previously treated for TB for 1 month or more and was declared lost to follow-up in the most recent course of treatment and subsequently found microbiologically confirmed TB. A patient who has left the treatment in between and who didn't want to be followed up. Then diagnostic cases, So Ntep, the following are acceptable: sputum smear, microscopy for AFB. So what we'll use? Nielsen staining and fluorescence staining. Then we have culture. We can have LJ medium, liquid culture medium. Okay. Then we have rapid molecular testing, line probe assay, CD-NAT, TrueNAT, UltraNAT. Drug sensitivity testing can also be done with MGIT 916 system, okay, for both first line and second line drugs. And we can have an economic variant using LJ medium, again Lowenstein Jensen medium. Role of smear for acid fast bacilli. It is cheapest, simple and point of care confirmatory treatment. It is less preferred as single test due to several issues. Okay, so high level of agreement, more with increased number of bacilli. So more the number of bacilli in the sputum, more are we sure that the person has TB. So young children, they cannot spit the sputum out, so we have difficulty getting specimen. Poor sensitivity is there in possibacillary primary TB, okay, and does not differentiate from drug sensitive to drug resistant regime. Okay, then this is the grading for TB. If you get zero number of if you examine 100 fields and you get no bacilli, then it is negative. If you get 1 to 9 in 100 oil fields, then it is positive, it is scanty. 100 to 99 per oil immersion field in 100 slides, then it is +1 positive. These all are positive, +1 +2 +3. 1 to 10 bacilli per oil immersion field in 50 slides, or more than 10 AFB per oil field immersion in 20 slides. Okay, so this is the grading of the smears. Then X-ray pattern, we have highly suggestive patterns, that is hilar and mediastinal lymphadenopathy, chronic fibrocavitary disease, and miliary pattern. Then role of MTB culture. Now you see, we can have in past we used LG medium, now we don't use it, now we used liquid medium, NGIT, Mycobacterium growth indicator tube. Okay, so and this is available through NTEP. So diagnosis yield improved with this liquid culture. Okay, newer rapid technology, we can use TrueNAT, MTB, RIF, rifampicin diagnosis, then expert MTB, rifampicin ultra. So these TrueNAT and expert we read above. So what are the processes for you can see there's a 2-step process. DNA is extracted and then it is added to the strip. Ultra may replace expert in the near future. Why? Because we can use it in possibacillary patients, children, HIV, TB, comorbidities. And this, we need samples like GM. Okay, we need to centrifuge the samples. Gastric aspiration. Then CBNAT algorithm. If MTB is detected and it is rifampicin resistant, then we'll see if there is history of previous treatment. If there is history of previous treatment, we'll refer him to a DRT center, TB center. If there is no history of treatment, we'll again repeat the CBNAT. If it is resistant, go to the DRTB center. If it is not resistant, we'll do line probe assay and treat as per DST if it is positive. Then if it is TB but rifampicin sensitive, okay, then if there is previous history, then treat him as a patient, okay, as a old patient. If there is no history, then treat him as a new patient, okay. Then if it is detected and it is rifampicin intermediate or invalid, then again do the test, okay, test again should be done. Then if MTB is not detected, so you have to rule out other differential diagnosis. If there is error or no result, you have to again do the test on same sample if available. If it is invalid, again do the exam. Then diagnostic algorithm for pulmonary TB. So if you have pulmonary person with a TB, you'll do the smear examination and chest X-ray. If the smear examination is positive and chest X-ray is also suggestive of TB, it is microbiologically confirmed that the person has TB. If the smear positive but X-ray is not suggestive, then also it is confirmed TB. Now, if the smear is negative but X-ray is suggestive, so it is on the basis of clinical grounds that we have to see. So if MTB is detected, CBNAT is done. If MTB is detected, we'll see if it is rifampicin sensitive, intermediate or resistant. If it is sensitive, it is TB. If it is intermediate, we again do the rifampicin and we go for line probe assay. If it is rifampicin resistant, we refer him to DRT center. Okay, if MTB is not detected on CBNAT also, then we go for alternate diagnosis and refer to the specialist. We can clinically diagnose the TB or give an alternative diagnosis. If the smear is not negative, if the smear is negative and not available, and chest X-ray not suggestive of TB or not available, then we'll see if the clinical suspicion is high or not. If the clinical suspicion is high, then we'll go for CBNAT. Otherwise, we'll leave the patient for another diagnosis. So people living with HIV, they are directly go for CB now. Okay, so they don't go for sputum smear examination or chest x-ray, they directly go for CB now. You can see people living in HIV. Diagnostic workup. Based on CB-NAT result, the patient will be categorized as microbiologically confirmed drug sensitive rifampicin resistant TB. In case rifampicin intermediate result, get an additional CB-NAT done to get valid result, and second one should be occasionally a additional specimen will be sent to the nearest laboratory or DST culture and drug sensitivity center for line probe assay and liquid culture and DST drug sensitivity as appropriate. Okay, now this is for extrapulmonary TB. So we'll take the specimen from appropriate site. If it is available, we'll do CB-NAT. If MTB is detected, we'll see it is sensitive, intermediate, resistant. If it is sensitive, we'll say it is confirmed TB, extrapulmonary TB. If it is intermediate, we'll do again CB-NAT, and if it is resistant, we'll refer him to DRT center. Okay. If the second specimen is also intermediate, then we'll go for liquid culture or line probe assay. If the specimen is not available, but if CB-NAT is not available, liquid culture can also be done. If it is positive, it is positive. If it is negative, then there is no TB. If the specimen is not available, we'll see high clinical suspicion, and we use other diagnostic tools, and we'll refer him to a doctor, specialist, and he can diagnose him on the clinical basis or go for an alternative diagnosis. Thank you.